Good evening and welcome to our educational webinar on Lapiplasty 3D bunion correction. We appreciate you joining us. I'm Kendall Rock, social media specialist at Treece Medical Concepts. Treece Medical is the company who patented the Lapiplasty procedure and manufactures its instrumentation and implants. Our goal here tonight is to provide you with quality information because we know that making a surgical decision is a decision that isn't taken lightly. We applaud you for empowering yourselves with information to make the best informed treatment decision you can. I will quickly get a couple of housekeeping items out of the way so we can get right into the presentation by our surgeon speaker, Dr. Kellen. First of all, you are listening to the webinar on mute, but you can ask questions throughout by clicking on the questions tab in your control bar and typing them in. We'll be answering questions sprinkled throughout the presentation and at its end. We'll also be emailing you an archived link of this presentation to refer back to within just a few days. Lastly, I know that you will enjoy our speaker, Dr. Cohn, but if you are attending outside of Illinois, you can find locally trained Lapiplasty doctors in your own area to consult with by visiting our patient website, www.lapiplasty.com. There is a prominent Find a Doctor button at the top of the homepage, searchable by zip code. With all that out of the way, I'd like to introduce tonight's surgeon speaker, Dr. Kellen. Dr. Kellen is board certified by the American College of Foot and Ankle Surgery in reconstructed foot, ankle, and forefoot surgeries. As the president of the Illinois Association of Podiatric Physicians and Surgeons, the largest association of podiatrists in Illinois, he leads efforts to advance podiatric medicine in the state. Dr. Kellen is also head of the podiatric section, elected among over 30 peers at Northwest Community Hospital in Arlington Heights, Illinois. With extensive experience in foot and ankle surgery, Dr. Kellen has developed specialized expertise in bunion surgery, utilizing cutting-edge techniques to restore function and alleviate pain for his patients. Known for his dedication to patient-centered care and advancements in surgical techniques, Dr. Kellen has played a key role in organizing and creating medical conferences and educational programs to help further the field of podiatry. Dr. Kellen frequently shares his insights at webinars and workshops, helping to educate both his peers and the broader medical community. Dr. Kellen operates at a thriving practice in Arlington Heights, Illinois, where he combines compassionate care with surgical precision to help individuals achieve optimal foot health. We appreciate Dr. volunteering his time tonight, and I will return to moderate a question and answer segment at the end. And now for Dr. Kellen.
Hi, thank you, Kendall. Hi, everybody. Thanks for joining us tonight. My name is Dr. Kendall. So welcomely introduced me. I am going to read a few of these through, essentially, and then I'm here to answer any and all questions that anybody has to ask. So first, Lapiplasty has been FDA cleared for 9 years, almost 10. It's a patented procedure manufactured by Treece Medical Concepts. It requires advanced training, not offered by all surgeons. All surgeons are proficient on cadaver lab before entering any operating room. To date, there's over 100,000 patients that have been treated with Lapiplasty. Most insurances, including Medicare, have covered this. I've had Medicaid cover this. I haven't had any problem with any insurance. And certainly Lapiplasty.com is a great resource to answer questions and get some FYIs from the get-go. Next slide. As in any surgery, there's no guarantees. The overall satisfaction rate for Lapidus in general is in the upper 80%. I think with Lapiplasty, I've had even higher success rates. Things that can happen with any surgery is an infection, reactions to the hardware, pain, discomfort, sensations that are abnormal due to the presence of the implants. It does run close to tendons and muscles that can be slightly irritated. Usually this resolves with just waiting. Typically I have people wait for about a year before entertaining any hardware removal because most of the time this resolves on its own. Bending, cracking, loosening of the components is possible. Non-union is when the bones don't heal correctly together. Osteoporosis may increase this risk. I already mentioned delayed correction in alignments is possible. And something called stress shielding can happen from too much hardware, allowing the bone to become less dense with time. Not something that I've seen in my practice. Bursitis, also something that I haven't seen in my practice with this procedure. Next slide, please. Bunions, more than a bump. Anybody on here, I'm sure, has seen this diagram from Lapiplasty already, but it's certainly true to, and something important to go over, that a bunion is not simply a bump, it's an anatomic deviation. It comes from an unstable first ray, that is the metatarsal, the bone behind the big toe. And as it becomes loose and unstable, it tends to drift outwards and upwards, forming a large bump on the side of the foot. And the correction, as you can see in this picture, is to stabilize that bone into its corrected position at what they call the root of the bunion. Next slide. Bunions are a complex deformity. They, like I was saying, they're caused by this unstable joint in the middle of the foot. That would be that bottom red arrow of the three showing the unstable joints. As the bone leans out, though, it's at the top arrow where you see the bump in your foot. Next slide. So this is a picture here showing a generic traditional bunionectomy. In these type of surgeries, what we do is we make what's called an osteotomy, or a controlled fracture. This one shows a fracture at what would be considered the neck of the metatarsal. And once the bone is cut into two pieces, it's pushed into what appears to be anatomic alignment to reduce the bump on the side of the foot, and held in place with a screw. It's true that this would be considered a 2D surgery in that we are pushing the bone over but unable to rotate it in most cases. And that's where you get a bunion that looks corrected on the outside but not necessarily in alignment internally, which could lead to recurrence or continued pain. Next slide. Here's a picture showing the Lapiplasty reduction clamp. So this clamp, we can put the bone into normal alignment. It's actually a very nifty and simple clamp. It's been tried to be recreated by at least 3 or 4 or 5 different companies. The clamp is in place after everything is prepared. This is all of about 5 seconds of getting your bone into normal alignment. And once it's in better alignment, we put the hardware in to let it fuse. Next slide. Questions. How do you determine if a patient is a good candidate for Lapiplasty procedure? This is a case-by-case basis. Certainly it requires looking at the patient from head to toe, past medical history, surgical history, medications, age, expected activity, degree of their bunion. Is there truly unstable joint at the base of the metatarsal, which I would say is most of the time the case. In my practice, I'm doing Lapiplasty on at least 9 out of 10 bunions that come through the office, and the ones that aren't getting Lapiplasty are patients typically that would do better with the Lapiplasty in a book answer, but in reality it's just not the right procedure for them for one of those above reasons. Lapiplasty does truly treat bunions of all severities. Certainly any severe bunion is going to get a Lapiplasty, but based on your age and all those other factors, I'm using Lapiplasty for mild and moderate bunions quite often too. Next slide. Can I get the Lapiplasty procedure if I already had a previous bunion surgery? This is definitely a true statement that you can. I have fixed previous bunions that have been corrected with a 2D osteotomy or let alone a simple shave of the bone. And the problem with those procedures, like I stated, is it doesn't prevent the progression of the bunion with the stabilizing procedure at the base of the bone. The problem with revision surgery is the bone has already been compromised and changed, and it is more difficult to get a perfect bunionectomy when it is in a revision status. But typically, yes, almost always, if there's a revision on the table, it's either a Lapiplasty, typical Lapiplasty procedure, or if it's unsalvageable, then a joint fusion at the first toe, meaning that your toe will not be able to bend anymore using Lapiplasty's other hardware. Next slide. What may happen if I don't treat my bunions? If you don't treat a bunion, it can slowly get worse. It can stay the same. Time will tell. It's hard to decipher. Certainly younger people, I expect it's going to worsen over time. Somebody that comes in with a bunion that doesn't cause any irritation or pain and they're 50, 60, or 70, I usually tell them to wear a wider shoe and live with it. It all depends on how it's feeling. The procedure is not going to change if you let this bunion sit for a year, 2, 5, or 10. Though if the bunion does get worse, it is harder to correct. There is a higher chance for complications the worse the bunion is to start, which is supported in the literature. So with that said, if it's becoming symptomatic, it's probably not going to go away, and it may get worse and harder to correct. Next slide. Here's a few pictures. These aren't my surgeries, but just some examples of bunions that have been corrected with Lapiplasty. And one thing to notice in these pictures, it looks like they use just a small incision on the top of the foot. Sometimes there's a second incision at the bump to try to rebalance the soft tissue after the toe has been corrected. I'd say it's about 50-50 in my practice whether I'm doing the incision just on the top. The incision on the top is 2 inches long, measured before surgery, and almost always left at 2 inches. And then the incision on the side is going to be smaller. Next slide. Recovery. So I did read through these slides before, and I'd say this is in line with what I practice. Most people, I have them use crutches for the first 2 weeks, maybe putting weight on their heel, especially when they're standing still, but ultimately using the crutches for getting around. And for the most part, it's going to be tender, and if you walk on it, it's going to hurt worse. In those first 2 weeks, you're not going to want to walk very much anyhow. After 2 weeks, if the stitches are doing well, we take the stitches out. Patients are put into these big cast boots, which I am sure most have seen around. I leave people walking around in those for a month. You could take it off when you're on the couch for bedtime, what have you. After that month, we take another set of x-rays, and if everything's holding steady, then we move into gym shoes, which is exactly usually in that 6 to 8 week timeline. And then I would agree it's at least 3 months, 3 to 4 months before I let people start running or jumping. Probably more like 4 to 6 before people are doing that comfortably without thinking about their bunion. Next slide. Lapiplasty is covered by insurance. Um, in the bunions that I've treated, I have not had any problem with the insurance not covering the procedure.
Thank you very much, Dr. Cohn. We've had several questions come in this evening. Thank you for the great audience participation. We'll do our best to answer most, if not all, of the submitted questions now. If you haven't yet already, as a reminder, you may ask a question by clicking on the questions tab in your control bar and typing it in for us. So, first question that I have for you, Dr. Cohn, that has come in is, can I have both my feet corrected on the same day at the same time?
This is something I would highly recommend against. It's tough enough. This is a no joke procedure. It's a midfoot fusion. It is outpatient, but it is a painful procedure, and you're not going to be able to walk on your foot most likely for 2 weeks. And if you do, it's going to be very tender to do so. You're going to want to have a good foot to stand on to do this. Most of the time that I've done patients, usually about 6 months apart. A lot of school-aged people I am doing year apart, just for summer break or winter break, what have you.
Great, thank you. If a patient's feet do not currently hurt, should they have the procedure done?
I would be hard pressed to do a bunion surgery on somebody with no pain. I suppose there may be a place for it, but in my practice, I would give shoe recommendations, make orthotics that are specific for bunions. There's a brand of shoes called Ultra, A-L-T-R-A, that is focused on bunion accommodations, and that's usually where I start.
Great, thank you. Another question that has come through is there an age limit for this type of procedure?
That's a really good question. The youngest I have done the Lapiplasty on, I believe, was 16 years old. The bones do need to be finished growing. This is something that we can look at x-rays to help determine. Most children in high school, I try to wait until they're 17, 18 at least. On the other end of things, I have done a Lapiplasty. I think the oldest would have been 75 years old. I know some of my associates have done slightly older. There's no contraindication with age, although when patients get into their 70s and 80s, a lot of times I'm trying to find a simpler answer that is more reasonable, just given their abilities to get around and their social support, and their comorbidities are typically worse as you get older as well. Bone density does become a concern in my opinion, although the papers say otherwise. But that would be my answer. Most of the people I'm doing, I'd say, are in their 50s, some in the 40s, some in the 60s. At the upper 60s and 70s, I start to try to find other answers a lot of the time.
Thank you. If a patient needs to have both of their feet corrected, in your experience, how long do you advise in between the surgeries?
I think 6 months is a reasonable answer. I know some doctors will push ahead at 3 months. Problem is you won't know if you're ready at 3 months until it is 3 months. And a lot of people aren't going to be ready at 3 months.
Great, thank you. In your experience, do you recommend physical therapy to your patients after undergoing the Lapiplasty procedure?
That's another good question. I'd say half the podiatrists do use physical therapy, the other half don't. I'm on a case-by-case basis. I'd say most patients do fine without it. If you're having struggling getting around, getting your foot moving, If you have a lot of swelling, if the scar is tender, there's definitely a place that for physical therapy to give you the best results, and it's worthwhile to go through it.
Great, thank you. How long until after undergoing the Lapiplasty procedure can a patient drive?
On the left foot, I let people drive once they stop taking the pain medication, the opioids, which you cannot drive while you're taking. I tell people to plan for about 2 weeks not driving. Obviously, the right foot's more complicated. You can't drive with a cam boot, the cast boot. So it's at least a month before you're going to start driving with a special surgical sandal or sandal made for driving, but I would plan for 6 weeks.
Great, thank you. If a patient has had a bunionectomy in the past, are they still eligible candidate for this type of procedure?
Yeah, again, it depends on what they had in the past. Most of the time, a joint fusion at the big toe, meaning that we fuse your big toe in perfect position and it won't bend anymore, is the secondary answer, and that also is going to be using Lapiplasty's other hardware set.
Great, thank you. How soon can a patient shower or get their foot wet after undergoing the Lapiplasty procedure?
So for showering, it's going to depend on when your skin is healed. Traditionally, for any kind of foot procedure, regardless Lapiplasty or not, it takes 14 days for the skin to heal. It's usually slightly shorter for face, chest, anywhere else, but for whatever reason in the feet, due to the swelling, most likely it takes about 2 weeks. Some people considerably longer.
Great, thank you. How soon will a patient be able to return to physical activities, including going to a recreational gym or outdoor sports?
So at 2 months, people are able to start walking in their normal shoes, doing their normal routine. If they're doing well at 3 months, then they can start to slowly progress into more aggressive activity. A lot of people, it takes more like 4 to 6 months though before they're really comfortable without having to think about their foot swelling.
Great, thank you. If I have a job that requires me to be on my feet all day, how soon after undergoing Lapiplasty can I return back to work?
So this is also highly variable. These days, a lot of people work from home or have desk jobs, especially if it's your left foot and we're not concerned about driving. I recommend 2 weeks off no matter what you do, just because you're going to be taking pain medicine and not ready to go to work with your full attention. However, people that are standing on their feet, it depends on, do they need to wear a steel toe boot? Are they standing, lifting, carrying, going up ladders? Or are they just walking around here and there as a cashier or something like that? So for example, a cashier, right foot, they're able to drive it a month and they can start thinking about going back to work at probably a month. However, somebody with a heavy duty job and has to wear steel toe boots and can't go back to work with the cast boot, they're gonna plan on 2 months of having to be out of work.
Is the procedure an outpatient procedure, and how long does it typically take in your experience?
It is outpatient. I personally give every patient something called a popliteal block. This is a specialized lidocaine block behind the knee performed by the anesthesiologist that will keep your foot completely numb for 1 to 3 days. And the procedure itself takes about an hour, hour and a half. That being said, a 7:30 surgery, the patient's going to have to show up at 5:30 to the hospital. We're not going to truly get started probably until 8 o'clock, 8:15. So an hour and a half later would be 9:45. And then there's getting wheeled out, 10 o'clock. They're going to be waking up groggy, and then they're spouse will come and see them probably not until 10:30. So it feels more like 3 hours for whoever's waiting in the waiting room.
Great, thank you. What type of anesthesia is used for this type of procedure?
It's called a monitored anesthesia care, or MAC sedation. Layman's terms, I would suppose, called twilight sedation, similar to a colonoscopy. This is where you would get an IV with medication running through the IVA, such as propofol or a derivative that's going to put you in twilight where you have no recollection of what's going on. However, it's much safer. You're still breathing on your own, and there's no tube in your throat that can cause irritation. It's less dangerous than general anesthesia, less complications. And then I supplement that with what's called the popliteal block, where the anesthesiologist is going to numb your entire leg from the knee down. And this I've seen lasts up to 3 days in some cases, but typically lasts about 1 day.
Great, thank you. If a patient smokes, will that prohibit them from being a candidate for this type of procedure?
Yes.
If a patient lives in a 2-story house, how should the patient plan to get upstairs or downstairs? Should the patient walk up or try to find alternative ways to going upstairs, or plan to stay on the first floor for some time being?
Staying on the first floor is something I've seen quite often, but putting weight on the heel is typically okay. As I said, the surgery is all in the middle of the foot and the forefoot. So if you're able to use the cam boot and slowly use the railing to take some weight off and use just the heel of the boot on the stair, that's how people go up and down the stairs. Usually walking sideways when you're going upwards to help make sure that you're putting the weight only on the heel.
Great, thank you. In your experience, can someone recover safely living alone with enough preparation, or is it recommended to have someone there to help out for the first initial few days?
The first couple days, you would like to have somebody close by. It's highly variable. Some people come into my office, don't take a single pain pill. Other people are struggling quite a bit, even 1 or 2 weeks after surgery. And if you're a person that unfortunately has that much pain, it's going to be difficult to do things on your own, standing on one foot and taking the medication, which can make you woozy, and trying to do the things you need to do. So it certainly helps to be prepared beforehand with meal prep or anything like that on your own, or having somebody with you for the first couple of days.
Can a diabetic have this procedure done?
Yes. Diabetics need to have their A1C in good order. Under 7 is the goal. Under 7.5 is the gray area. A lot of patients with diabetes have concomitant arterial disease, which could preclude them from having the surgery, but diabetes alone is not going to be a contraindication.
If I have arthritis, can I still have the Lapiplasty procedure done?
So that would depend on what you're speaking to. I would assume you're meaning arthritis in the great toe joints.
Yes.
There is a place for mild arthritis where the Lapiplasty can improve the position and functioning of the joint. Something called functional hallux limitus is a specific problem that Lapiplasty actually would be the correct procedure to use in that situation. However, if the arthritis is tender and it's not a functional hallux limitus, a true arthritic problem, a different procedure such as a joint fusion, joint replacement, or joint cleanup are typically used, sometimes in conjunction with a Lapiplasty. So that would be the answer for that.
Great, thank you. If a patient is currently taking a weight loss drug, do they need to stop taking the drug to have the procedure done, or can they still take it while undergoing the Lapiplasty procedure?
So this is a new problem that we've experienced since the Ozempic craze that started, I don't know, a year ago. The problem with Ozempic is it slows the stomach from emptying food. And this can cause something called aspiration, where you essentially vomit during surgery, and that vomit can go into your airway when you're sleeping and be a big emergency. For that reason, Ozempic, Wegovy, any of those other derivatives need to be stopped a week before surgery. And otherwise, it doesn't need to be stopped. It can be restarted soon after surgery as well.
Great, thank you. With the Lapiplasty procedure, will I have a scar? If so, how big will the scar be?
So every surgeon's different in this manner, but with the hardware that I'm using, they're generation 4 plates, and the ones that I have been using most recently. The incision on top of the foot is 2 inches. I measure this exactly. It starts at the joint 1 inch towards the toes and 1 inch towards the ankle. And then the incision on the side of the foot, if it's needed, is typically slightly smaller than that first incision. It's going to become scars that typically fade with time.
Speaking of the hardware, does the hardware from the Lapiplasty procedure ever need to be removed?
There are cases that need to be removed. Lapidus, the generic term, or more technical, the first tarsal-metatarsal fusion in the literature, hardware removal is somewhere about 7%. Lapiplasty, in my experience, has been lower. I don't think, knock on wood, I haven't had to take out hardware for Lapiplasty. I've been doing this surgery for about 5 years.
Great, thank you. If a patient has a hammer toe, can they have that corrected at the same time as the Lapiplasty procedure?
Yes, yeah, it would be advised to do both at once.
Great, thank you. Is there any way to truly correct a bunion without undergoing surgery?
No.
Great, thank you. I know we talked about this in the beginning, but can you describe again what the first initial 2 weeks look like post-operation?
Certainly. So I do surgery typically on Thursday or Friday. The patient has a block. I call them the next day. Most of the time they're still numb. I usually see them on Monday, and then it's at that time I find out whether their numbness wore off on Saturday or Sunday, but most people are numb for the first day or two. That first initial visit, less than a week from surgery, is to just take the bandages off, answer questions, see how the pain score is, make sure I don't see any infection or immediate complications. We put you back in the bandage, we put you back in the boot right away. I have people on crutches those first 2 weeks for the most part. Like I said, you can put weight on the heel if you're standing still. However, the more you keep your foot down, the more it's going to swell and cause pain, cause tension on the stitches, delay the healing of the stitches, and make your scar worse. So for that reason, I find that if people stay off their foot completely for those first 2 weeks, tend to do the best. From there, if the x-rays look good, the skin looks good, people can start walking in the boot to their tolerance. Pain is something that you don't want to push through, so if you are having discomfort, you should slow down, do less, elevate, talk to your surgeon. But typically, after the first 2 weeks, people do well, starting to walk, ditching the crutches after the first couple days of walking. And the next visit, around 6 weeks, we take them out of their boot and put them into a good sturdy gym shoe.
Great. Thank you for going over that again. Do patients lose flexibility in their toes or feet after undergoing the procedure?
The fusion at the midfoot, the tarsal metatarsal joint, where the Lapiplasty hardware lives, is going to stop the motion at that joint. That is what's considered a non-essential joint. It really is only supposed to have about 5 degrees of motion that you would not notice is there or not. Most of the time when we're doing this surgery is because that part of your foot is unstable or too loose and has too much motion, which is what has allowed your bunion to form. When we do the one incision on the top, if I'm able to correct the bunion without making the second incision at the front of the foot, essentially the big toe joint is left untouched and the motion should be the same or better after surgery. However, in about half the cases, I do need to do some soft tissue balancing and tighten up the stretched out tissue on the side of the foot to get the toe in perfect position, and this scar tissue can limit motion to a certain extent at the big toe joint.
Great. Thank you. In your experience, what do you prescribe to patients to take post-operation to combat pain or swelling?
Most of the time I am giving Norco, formerly known as Vicodin. Sometimes I'll supplement this with something called Toradol or Ketorolac, which is a prescription NSAID somewhat related to Advil. Most people get one prescription and do well. Some people get a refill, but that's less than half.
Great. Thank you. Couple of repeat questions for a couple people that joined later. How long until I can get my foot wet or swim after Lapiplasty?
So this is going to depend on when your skin is healed. We check this first at about 2 weeks. People that are healthy, younger side, compliant, meaning that they stay off their foot, the skin heals quicker. And at 2 weeks it's healed. We take the stitches out if they were non-absorbable, and you can start getting your foot wet. Swimming is another level of wet. That's typically at least a month after surgery. I would plan for 6-8 weeks though before you're going on any swimming pools.
Another repeat question would be, how soon would you recommend a patient to travel by vehicle and or by plane, boat?
I like to have patients local for the first 4 weeks after surgery. Really, in Lapiplasty case, more like 6 weeks, 4 weeks in general for any surgery. And this is because of any complications that may arise. I can't treat over the phone typically. There is concern for blood clot when you're immobilized, so that is a preclusion for using the airplane for at least the first 2 to 4 weeks after a big surgery like this anyhow.
Can you comment on a patient who has osteoarthritis? Can this person still undergo the Lapiplasty procedure?
So it's going to depend on where the arthritis exists. And if the big toe joint is arthritic and painful, typically the telltale sign between a painful bunion and a painful arthritic toe is, does it hurt when you're barefoot? A bunion most of the time hurts from poor shoe fit, being tight in shoes, rubbing on the inside of the shoe, where arthritis is going to hurt when you're barefooted and the joint is not protected. This is going to be a case-by-case basis question, though.
Great, thank you. Another repeat question that has come in again once later is, what is the age requirement for this procedure to be done?
So I find that it is best to wait until your bones are finished growing in the foot. This is a little bit younger for girls compared to boys. Generally speaking, about 2 years after your menstrual period starts is when the foot is done growing. Again, I think the youngest I've done was a girl who was 16. Usually I'm trying to have them wait until they're closer to 17, 18. At the other end of things, I'm feeling pretty confident in patients in their 60s. When we get into their 70s, I have done the procedure, but a lot of times I'm looking for alternate answers, maybe more of a traditional bunionectomy. Patients in their 70s tend to have more comorbidities, less social support, less mobility to start, which all plays into the decision, not just the fact that they're in their 70s.
Great, thank you. And we have time for a few more questions. Another question that has come through is, will I ever be able to run again?
The goal is yes, absolutely.
Perfect.
There's no guarantees with this procedure. You know, the correction itself could be perfectly aligned and patients can hurt. It could be imperfectly aligned and patients can be very happy because it doesn't hurt. But the goal is to get your foot in an anatomic position that should be less irritable due to the corrected position and allow you to run better.
Great, thank you. Will a patient be able to wear their high heels again?
Other than I don't recommend high heels, a Lapiplasty should not change the height of your heels that you can wear.
Thank you. How does a patient go about scheduling a consultation to get more information on their bunions and or the Lapiplasty procedure?
You can contact our office to schedule an appointment with me or go on lapiplasty.com and find a local surgeon who is experienced in Lapiplasty.
Great. Thank you, Dr. Khan. So as we begin to wrap up now, if your question did not get answered or you think of something later that you wished you had asked us, feel free to reach out to us. Our email address is patientinfo@treece.net. You can also learn more or find a local doctor by visiting our patient website, www.lapiplasty.com. Don't forget that as a follow-up, we will email all registrants an archived webinar link for reference. We hope you found this information presented tonight helpful. Dr. Cohn and I appreciate you joining us this evening. Have a great rest of your evening, everyone.
Thank you, everybody.